The Amulet 5-year follow-up, I think, is extremely important because most of the clinical trials that we come across either end at 12 months or 18 months. And it's really important for a therapy that has long-term implications to see how it performed over a longer period of time, right? So from that perspective, Amulet really provides us with the appropriate uh, information that's much needed in evaluating the safety, efficacy, and the long-term impact of appendage closure using a dual seal mechanism closure device like Amulet over a period of 5 years. So Watchman 2.5, Watchman Flex, Watchman FLX Pro, these are all single lobe devices that have some inherent limitations in terms of larger osteo or proximal lobes, even though some of these limitations are partly sort of solved by the subsequent iterations of the Watchman device. But still, mechanistically, the design is very similar. The lobe and the disc construct of the amulet really fulfills a gap that is otherwise difficult to address by a lobe type of a device like Watchman, whether it is a shallow appendage, appendages that are heavily trabeculated and don't have much of a landing zone, and appendages that have significant proximal lobes, appendages that are relatively large. These are the ones where I think a lobe and disc type of a closure mechanism device has a significant advantage or a single closure mechanism device. So when you really take that into consideration, there is a class design effect that you should not ignore. And that's exactly what the Amulet device highlights, despite iterative improvement in the Watchman design or the subsequent versions that have come out and that are currently in the marketplace. So as you have noticed in the trial results, the effectiveness of appendage closure is significantly better with a dual seal closure device like Amulet. That means over 15% less um, buried device leaks were noted with Amulet. That means a significant number of Watchman devices had buried device leaks, incomplete closures that really explain the the potential for systemic thromboembolism. And when you have a larger leak and you're off of anticoagulation, then there is a bigger chance of a clot formation, and those clots can result in a significantly impactful stroke. I mean, this is something that we talk about all the time with strokes related to atrial fibrillation. So AFib strokes in general are large bodied and they can cause a significant amount of brain damage because of the sheer size of the thrombus burden. So I suspect what could have happened in these cases is since a large number of the Watchman group patients had significant peri-device leaks, I suspect that the stroke burden in these patients was significantly higher, thereby the overall disabling or fatal stroke numbers were significantly higher. I think these results are very welcome from a physician community because it gave us a reaffirming assurance of the class effect of the left atrial appendage closure devices. That means we've seen in the whole clinical trial, the overall incidence of stroke was very low, 1.6% over 5 years. I think that's a fantastic number. So that reaffirms our trust in these devices and the performance of these devices. And so these devices are here to stay. It also provides us a great opportunity to have more than one device in our hand. I mean, obviously, not every patient can be treated by a single type of device. And having the second option really opens up the opportunity to effectively close fatal appendages in general that otherwise would be hard to do. And the Amulet IDE also gives you the reassurance that the lobe and disc type of a device closes these appendages a lot better and has significantly lower fatal or disabling stroke risk, which in turn can translate into more effective outcomes for the patients. So the results are very positive as far as the entire field of appendage closure is concerned. It also opens up the opportunity for a second device that has very unique features that can be leveraged. So my suggestion to my colleagues is don't go into a procedure wanting to put in one device or the other. Go with an open mind, do your legwork, and do the intraprocedural imaging like a TE or an intracardiac echo, and do an angiogram too, and get a proper assessment of the appendageal anatomy, and then decide which device you want to put in and how you want to put it in. And as a result of which, you have a much higher likelihood of giving your patient the right device rather than committing yourself to one or the other. I think Amulet is a unique device. It gives you a design advantage that is hard to come by with the other devices. The lobe and the disc really affords you a greater probability of closure for wider ostia, shallower appendages, appendages with proximal lobes, and accounting for all the little quirks that are otherwise difficult to overcome with a single lobe device. So then in addition to that, the smooth surface of the disc really helps proper endothelialization over a period of time. And this also accounts for appropriate closure. So just knowing what we know about the device, its overall long-term efficacy and its performance, even though it's a first generation device, I'm a lot more exciting to see that the next iterations and the next generations of the Amulet device could do even better. So that's one reason I think it's important to keep options open and really consider Amulet in your workflow from time to time. So I would say a vast majority of appendages can be closed by one device or the other, but then there are definitely a certain specific group of anatomies, as I have outlined earlier. Amulet has an edge. So I think that's something that one has to think about. And if you are somebody that has never used an Amulet device, don't let your most difficult appendage cases to be your first Amulet closures. My advice to you is pick regular, normal-looking appendages until you get some experience under your belt, and then move on to tackle more difficult cases as you go forward, so you get more comfortable with this device.